Hey everybody, welcome to this case-based NCLEX RN review session, and today we'll walk through a complex clinical scenario that will challenge you to think critically, recognize patterns, and make safe and timely decisions using the clinical judgment measurement model. And as we move through each item, I want you to focus on how you interpret the data, prioritize care, and evaluate those outcomes just like you would in real practice. Let's get started.
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Here's our first test item. This is a bow tie. And let's scan through each piece of information here. So this is a case of a female patient admitted to the medical unit due to worsening of multi-system symptoms. Now here in the history and physical, this is about a 28-year-old female with a chief complaint, a 4-week history of intermittent fevers up to 102.1 degrees Fahrenheit, drenching night sweats, unintentional 15-pound weight loss, progressive dyspnea on exertion, and for her history of present illness, she engages in transactional sex work, reports unprotected intercourse with multiple partners over the past year, expresses shame about human immunodeficiency virus risk, and fears judgment, which delayed seeking care. She had a history of untreated syphilis diagnosed 2 years ago. There's occasional cocaine use, and she resides in a homeless shelter, lacks health insurance, reports food insecurity. She is cachectic with severe weight loss and muscle wasting. She's fatigued with oral hairy leukoplakia, bilateral axillary lymphadenopathy with a size of about 1.5 centimeters. It's non-tender, and with petechial rash on lower extremities. Now moving into the next section, we have the ongoing information here. For the initial diagnostic findings, she's tested positive for the HIV-1 antibody, so this confirms her new HIV diagnosis. Now, she's admitted to the medical unit for antiretroviral therapy, initiation, and evaluation for opportunistic infections. Developed worsening dyspnea, productive cough, and fever spiked to 102.6 degrees Fahrenheit. Sputum culture positive for Mycobacterium avium complex, or MAC. Chest imaging shows bilateral ground glass opacities, raising concerns for immune reconstitution inflammatory syndrome, or IRIS. Patient's anxiety escalated, leading to refusal of blood draws, stating, "These drugs are poisoning me." The healthcare team adjusts the plan to address clinical, psychosocial, and social needs. Now, moving on, we have our admission data. Her height is 5 feet 4 inches, and with a weight of 98 pounds, or 44.5 kilograms. Her BMI at 17.8 kilo squared meter, and her chief complaints are the following: fevers, night sweats, 15-pound weight loss, dyspnea on exertion, and with history of untreated syphilis, occasional cocaine use. And she does not have any known allergies. Again, her Initial assessment included cachexia. There's severe weight loss and muscle wasting. She's fatigued with oral hairy leukoplakia and bilateral axillary lymphadenopathy with some petechial rash on the lower extremities. Moving on to the vital signs on admission day, and we have the temperature of 101.4 degrees Fahrenheit, pulse rate of 96, respirations 20, blood pressure 110/70, 94% on room air. On day 3, which was 72 hours post-admission, her temperature is 102.6 degrees Fahrenheit, heart rate of 104, respirations 26, and blood pressure of 106/66, and saturation of 90% on room air. Now let's move on into the next section. We have the nurse's progress notes. On day 1 at 8 o'clock, this was entered. Admitted to the medical unit for new HIV diagnosis, reports fatigue, dyspnea, and fear of stigma. Oriented ×3, but anxious. Antiretroviral therapy. We have the following meds, or actually a combination. This is the dolutegravir, lamivudine, and tenofovir disoproxil fumarate. Initiated. Prophylaxis with trimethoprim sulfamethoxazole and fluconazole started. Case manager consulted for housing and food support. Day 2 at 1400, patient reports nausea, post-antiretroviral therapy dose, ondansetron 4 mg IV administered with partial relief, refused morning blood draw, stating distressed in medications, therapeutic communication provided to explore fears and build trust. Day 3, we have worsening dyspnea, productive cough and fever, saturation 90% on room air, sputum culture positive for Mycobacterium avium complex. Patient tearful, refuses blood draw, stating these drugs are poisoning me. Psychiatric consulted for anxiety, blood draw completed after reassurance, labs pending. So we have here the following healthcare provider orders. For the medications, these are the prescription. Number 1 is dolutegravir, lamivudine, tenofovir disoproxil fumarate daily, and we have the trimethoprim sulfamethoxazole 160/800 milligrams daily for the pneumocystis jirovecii pneumonia prophylaxis. We got fluconazole 200 milligrams daily for the oral hairy leukoplakia, azithromycin 1,200 milligrams weekly, and ethambutol 800 milligrams daily for the Mycobacterium avium complex treatment started day 3, and ondansetron 4 milligrams IV PRN nausea. For the diagnostic orders, we have the following: CD4 count, HIV viral load, comprehensive metabolic panel, complete blood count, sputum culture, chest x-ray, repeat CD4 count in 4 weeks, and consultations for infectious disease specialist, psychiatry for anxiety evaluation, case manager for social determinants, and other orders included supplemental oxygen, PRN for oxygen saturation less than 92%, monitor for signs of immune reconstitution, inflammatory syndrome. And let's move into our diagnostic test and lab results. On day 1, the CD4 count was 150 cells per cubic millimeter. And we have the HIV viral load, 450,000 copies per mLs on day 1. And the hemoglobin is 10.2 on day 1. White blood cells, 3.8. Platelets of 120. AST 68. ALT 82. And creatinine level of 0.9 milligram per deciliter. So I want you to review the entire record here, comparing day 1 and day 3 labs. And we got the diagnostic studies here. We have the HIV-1 antibody test, which was positive, resulted on day 1. We got the sputum culture, positive for Mycobacterium avium complex, and chest x-ray on day 1 showing normal results. However, on the day 3 x-ray showed bilateral ground glass opacities, and syphilis serology showed positive rapid plasma reagent, confirming and treated syphilis. All right. I hope that you were able to capture those important aspects before you're going to proceed answering the bow tie question. Now, for you to answer this test item, I want you to, again, go back into the case scenario. You're caring for this patient who just started antiretroviral therapy 3 days ago. Now, this patient is getting worse, having some shortness of breath. They have a fever of 102.6 degrees Fahrenheit. Their oxygen saturation is down to 90% on room air, and their sputum test came back positive for Mycobacterium avium complex. Now, the chest x-ray also shows something called bilateral ground glass opacities, which is usually pertaining inflammation and infection in the lungs. Now, for you to approach this item, I want you to first pull together everything you know. So this person has just started the antiretroviral therapy. They have signs of respiratory distress. There's fever, and the test results are showing MAC infection. Now, the big question is, what's actually happening here? Is this a brand new infection? Is it a drug side effect, or is it something else? Now, your job is to figure out what fits with all the data. So you have to look for the patterns and the timing. Now, I want you to take action to stabilize this patient, especially anything that helps with oxygenation. And you need to watch the right signs to see if your interventions are working or if things are getting worse. Now, your task is to drag and drop the options into the appropriate sections of the bow tie diagram and select one potential condition, 2 actions to take, and 2 parameters to monitor. Now, we got the options in this table for the potential condition. The options are pulmonary tuberculosis, immune reconstitution, inflammatory syndrome, or IRIS. Is it antiretroviral therapy toxicity? Or is it sepsis? Or is it pneumocystis jirovecii pneumonia? The answer to this potential condition is immune reconstitution inflammatory syndrome, or what we call as IRIS. This is the best fit, and here's why. So when someone with HIV and they really have a low CD4 count starts the antiretroviral therapy, their immune system begins to wake up. But sometimes it overreacts to infections that were already there but flying under the radar. And this overreaction is called IRIS, or the IRIS. And the patient in this case has several red flags for it. They just started the antiretroviral therapy. Their immune system is rebounding, and there's also positivity to the Mycobacterium avium complex. Now, they're also having the inflammation and breathing issues as reflected in the chest x-ray, right? It said something about bilateral ground glass opacity. So this is not a new infection. It's basically the immune system that's suddenly attacking something that was already present. And so if you selected the other options, let's say the antiretroviral therapy toxicity, well, we know that medications in ART can cause side effects like nausea or mild liver changes, but they don't usually cause shortness of breath or lung findings like this patient is having. And when you look into the liver enzymes, the AST and ALT, they're only slightly elevated, but they're not bad enough to blame the medications, and that's why it's not the best answer. Now, if you selected pneumocystis jirovecii pneumonia, yes, people with HIV can get this lung infection, but this case already has a known MAC. Go back into the data, we have that positive for Mycobacterium avium complex on their sputum culture. And the timing points toward IRIS rather than a brand new pneumocystis jirovecii pneumonia infection. Also, when you select PCP or PJP, or the pneumocystis jirovecii pneumonia, it usually has a dry cough and worse oxygen levels than we're seeing in this patient. Now, if you selected sepsis, this is also incorrect. When you think that fever and tachycardia might reflect sepsis, but this patient's blood pressure is stable. So when you do go back into the progress notes, the patient's blood pressure is stable. There's no sign of infection that has spread throughout the body. So you have to eliminate that option. Now, if you selected pulmonary tuberculosis, this is also incorrect. Good thinking, right? But TB in immunocompromised patient is common, but the test did not find Mycobacterium tuberculosis. What we are seeing in this patient is Mycobacterium avium complex. A totally different bug, different condition. So eliminate pulmonary tuberculosis here. Now for the nursing actions, the options are administer broad-spectrum antibiotics, consult the infectious disease specialist, order bronchodilator lavage or bronchoalveolar lavage, and initiate supplemental oxygen, discontinue antiretroviral therapy temporarily, and administer azithromycin and ethambutol. What are these two nursing actions that you should implement? One of the two here is initiate supplemental oxygen, because the patient's saturation is 90%, which is borderline low. Basically, it's already low. And they're also having some trouble breathing. So when you administer oxygen, this is very immediate. It's basic, also life-saving intervention. Now, the next one is to consult the infectious disease specialist. This is a complex patient case. The patient has a new diagnosis for HIV. They also have an opportunistic infection and the immune reconstitution inflammatory syndrome. And so when you do this step, when you are notifying the infectious disease specialist, this can alert the team, and they're going to help decide if antiretroviral therapy should be continued, if new infections need to be treated, and how best to manage this flare-up. That's why you should select this option. Now, if you mistakenly selected to discontinue antiretroviral therapy temporarily, then that's not good. That might feel like a good idea during a flare-up, but stopping antiretroviral therapy can actually make things worse in the long run. What we usually do is to keep the ART going unless the patient is in a life-threatening situation. Now, another option here that you should not select is to administer azithromycin and ethambutol. We know that these are the right meds for the Mycobacterium avium complex, but they've been already started, and giving them again isn't the priority. What matters now is managing the respiratory distress. Now, if you selected order bronchoalveolar lavage, although this procedure could help in further diagnosing lung infections such as the pneumocystis jirovecii pneumonia, it is not within your scope of practice to order it. However, the nurse's priority is to stabilize the patient's respiratory status, and you have to communicate the clinical findings to the provider. Always think about the airway. Go by the ABC's framework here. Now, another option that you should not select is to administer broad-spectrum antibiotics. Now, these antibiotics are used when we don't know what bacteria we're dealing with. But here, we do know it's the Mycobacterium avium complex, or the MAC. So this is not needed right now. So I want you to eliminate that. Now, moving into the parameters to monitor, we have the options: serum electrolyte, CD4 count, and viral load, inflammatory markers, CRP, erythrocyte sedimentation rate, blood cultures, liver function tests, oxygen saturation, and respiratory rate. Now, these two answers should be, the first one should be oxygen saturation and respiratory rate. these are your go-to indicators because these will tell you how well the patient's lungs are working and whether the patient's breathing is improving or if they are getting worse. Now, the other choice that you should select is the inflammatory markers. We got the C-reactive protein and erythrocyte sedimentation rate, because these blood tests will help monitor how much inflammation is going on. And if the patient's CRP or ESR keep going up, then it means the immune system may still be overreacting, which fits with the immune reconstitution inflammatory syndrome, or known as the IRS. So the rest of the options here are incorrect. So if you selected liver function test, we know that these tests are very important for long-term monitoring, especially if we are worried about drug toxicity. But right now, the main issue is breathing, not about the liver. So you're not going to select this as the best answer. Another incorrect option is blood cultures. You're going to select this if you suspected sepsis and if our main concern is sepsis, but there's no strong evidence right now that the infection has spread to the bloodstream. That's why we are not selecting this. Now, if you selected CD4 count and viral load, these two will help us tell us how the HIV is progressing or responding to the antiretroviral therapy. It's good to know, but not relevant in this urgent respiratory situation. If you selected serum electrolytes, these are useful for many things, but unless there's a reason to think electrolytes are out of balance, it's not a top priority at the moment. So I want you to reflect on your answers here. Make sure that you go back into the clinical scenario so that you can eliminate those distractors. Now let's move on to our next item. We have a hotspot highlight test item. Now it says here, the nurse is reviewing the patient's admission assessment to identify findings indicative of advanced human immunodeficiency virus infection. And you're supposed to highlight those findings in the table below that require immediate follow-up. So we got the following information: oral hairy leukoplakia noted on the tongue. There's axillary lymphadenopathy, bilateral, 1.5 centimeters tender. There's petechial rash in the lower extremities, a BMI of 17.8. Blood pressure of 110/70. Lung sounds clear bilaterally. Hemoglobin of 10.2. CD4 count of 150 cells per cubic millimeter, a heart rate of 96 beats per minute, serum albumin of 3.2 grams per deciliter, and visual acuity of 20/25 bilaterally, serum sodium of 138 milliequivalents per liter. Now, in this test item, you're assessing a newly admitted patient who has that HIV. So the key here is to figure out which assessment findings could mean the disease has progressed to an advanced stage, and your goal is to spot those red flags that need to be followed up on the right, right away. Now, think in terms of how severe the immunosuppression is going on and whether there are signs of malnutrition or infections or complications like anemia or bleeding problems. And so one of those findings that you should highlight here should be this one. We got the oral hairy leukoplakia noted on tongue. So this is characterized by that thick, there's white ridged patch on the side of the tongue, and it's not something you can scrape off, and it's caused by the Epstein-Barr virus. And this is a major clue that the patient's immune system is really weak, typically seen when the CD4 counts are very low, under 200. And this basically is an early warning sign that opportunistic infections could be setting in this patient. And it also calls for antifungal treatment and further evaluation for other infections. Now, another finding that you should highlight is the axillary lymphadenopathy, bilaterally 1.5 centimeter tender. Because in someone with advanced HIV, the swollen lymph nodes can mean a few things. It says that it's an active infection. There's lymphoma or another HIV-related illness is going on. Now, you should not ignore these swollen lymph nodes because they have to be evaluated. They're going to need imaging, even biopsy, to figure out what's going underneath. Now, another thing that you should highlight here is the petechial rash in both lower extremities. So these are the tiny red spots or purplish dots on the skin. This could be related to low platelet count, which increases bleeding risk. And in this case, the patient's platelet count is already on the low side. And going back into the medical record, she has a level of 110,000 per microliter. So this rash is your visual clue that the blood is not clotting well. So you need to report this to the healthcare provider and possibly obtain an order for labs like maybe complete blood count, or even have an order for consultation for hematology if it's not in place yet. Another that you should highlight is the BMI of 17.8 per kilogram, or 17.8 kilograms meter square. So here, the patient is clearly underweight, and anything below 18.5 is considered undernourished. And for this HIV patient, this really raises some big concerns. And when they are having this poor nutrition, it's going to make everything worse about their healing, their immunity, could be body strength. And this patient might not be eating enough, or they might not be absorbing nutrients properly. So either way, nutritional support is really needed in this patient. Now, another thing that you should highlight is the hemoglobin of 10.2 grams per deciliter. That's low. This is considered as mild anemia. It's pretty common in people with HIV due to the long-term inflammation, possibly from bone marrow suppression or maybe poor nutrition. While it's not really an emergency, this is something that can contribute to their fatigue, their overall weakness, and it does need to be looked into. So you gotta include this one. Now, another thing that you should select is the CD4 count of 150 cells cubic millimeter. This is one of the most important findings because the CD4 cells are a key marker of immune function in HIV. And when the count drops below 200, it officially meets the definition of AIDS. And at this point, the patient is very vulnerable to infections, and they'll likely need the antiretroviral therapy and preventive medications to protect them from things like the PCP pneumonia or another infection called toxoplasmosis. Another item that you should highlight is serum albumin of 3.2 grams per deciliter. We know that albumin is a protein made by the liver, and a low albumin suggests either chronic illness, could be chronic inflammation, or malnutrition, all of which are very serious concerns in advanced HIV. And this one signals that the patient may have a poor prognosis unless their nutrition and inflammation are managed properly. So the rest of the options here are not going to need immediate follow-up, such as the blood pressure of 110/70. That's normal reading. It doesn't indicate immediate concern. Lung sounds as well. They're clear bilaterally, so there's no concern about that. Heart rate of 96 beats per minute, slightly on the high side, but it's not unexpected, especially if the patient is anxious or if they are febrile or dehydrated. They can have slightly elevated heart rate, but this is not going to call for an emergent action. And visual acuity of 20/25, it means that there's no sign of HIV-related eye issues like maybe cytomegalovirus retinitis, so eliminate this one. And the serum sodium of 138 is also on the normal range, so we're not going to be worried about electrolyte imbalance here. So for this test item, I want you to think about the bigger picture here. So I want you to ask yourself, which signs point to advanced HIV or something dangerous is happening in this patient. And anything that shows the patient is malnourished or immunosuppressed, or if there's any indication that they're high risk for bleeding, then those deserve your attention. Now, you have to disregard those stable vital signs or maybe normal laboratories. What you should focus on is to highlight those findings that will make or break the patient's immediate safety in this state. Now let's move into our next test item. We have a multiple response grouping item. So I want you to brace yourself here. We got like 4 categories with 6 options per category. Now it says here, the nurse is formulating the patient's care plan. Select the interventions appropriate for each category by checking the corresponding boxes. So the categories are the following: HIV opportunistic infection treatment. We have symptom and side effect management, psychosocial and preventive care, and lastly, monitoring. So in this case, you are the nurse creating the comprehensive care plan for this newly diagnosed HIV positive patient with the Mycobacterium avium complex result. And we know that this is an opportunistic infection, especially with an advanced HIV infection. So your nursing action will span across the treatment, the management of the symptoms, their psychosocial, preventive care, and also monitoring. So with these grouped interventions, I want you to classify these actions based on their primary purpose. So your strategy is to simply ask yourself if the action, if the main reason of this action is going to control the symptoms, if it's going to support the psychological aspect of the patient, or is it going to prevent any more complication, or is it more about monitoring, right? And so let's go into our first category here. What do you think would be the answers in this row? Now, one of those correct answers is to administer dolutegravir, lamivudine, tenofovir, disoproxil fumarate. This is the antiretroviral therapy, which is the triple combination. It is intended to suppress HIV replication. And when initiated early, especially when the CD4 count is less than 200, this is going to prevent progression to AIDS and allow immune system recovery. And this is known as the cornerstone of long-term HIV management. So make sure that you keep that in mind. Another intervention here is to start azithromycin and ethambutol. Now, I want you to recall the drug classes of these drugs. Now, these two medications, when used together, are aimed to be used as first-line treatment for a disseminated Mycobacterium avium complex type of infection. And for a patient with advanced HIV and low CD4 count, this is going to be beneficial for them. And this is also considered as a targeted antibiotic therapy. Now, what else do we need to do here? We're going to select provide fluconazole 200 milligrams daily. This is also ordered to treat oral hairy leukoplakia. Now, if you're going to review into the physician's orders, this is going to treat that infection caused by the Epstein-Barr virus, which is common in severely immunocompromised patients. Now, we definitely need to address those oral lesions to prevent secondary infections. Another thing that you should select here is to initiate trimethoprim sulfamethoxazole for pneumocystis jirovecii pneumonia prophylaxis. And this is given for patients with a CD4 count of less than 200 because they are at high risk for the pneumocystis jirovecii pneumonia, which is another life-threatening infection. And prophylaxis is both preventive and a life-saving measure. Now, the other two options are incorrect. If you selected administer acyclovir for prophylaxis, well, this is only indicated for herpes simplex virus or varicella infections. And if there's no evidence of herpes outbreaks, then administering this medication is unnecessary. Now, if you selected order baseline resistance testing for antiretroviral therapy, this one is very important for the healthcare provider to do before they place the patient on an antiretroviral therapy. But it is not our nursing responsibility, nor this is an urgent action in the immediate care plan. So eliminate this one. Now let's move on to our next category, which is all about symptom and side effect management. And one of the answers that you should select is to administer ondansetron as needed for nausea, because the patient had nausea after she took the dose. And of course, we know that ondansetron can improve adherence by managing the minor side effect, of course. Another answer that you should, or option that you should select here, is to provide supplemental oxygen for saturation of less than 92, because the patient's saturation dropped to 90%. It indicates that they have moderate hypoxemia. And this is very important for us to support their respiratory function. Another thing is to administer acetaminophen for fever. They had some fever going on at 102.6 degrees Fahrenheit. And so this is going to help relieve their discomfort. It's going to reduce metabolic demand, and it will also regulate their body temperature, which is very important, especially if they have systemic infections. Now, the other options, such as apply hydrocortisone cream for petechial rash, is incorrect here, because the petechiae that we are noticing is a hematologic issue. It's more about thrombocytopenia, not about skin inflammation. And if we're going to administer hydrocortisone, this isn't going to be ineffective. It does not address the root cause. Also, offer oral rehydration solution for dehydration is not appropriate here, because there's no evidence of dehydration. Although the patient complained about nausea, but there's no vomiting, no issue about diarrhea, and there are no abnormal laboratory values pertaining to the electrolyte counts. So this is unnecessary and is also potentially misleading in terms of prioritization. Now, if you selected administer lorazepam PRN for anxiety, this is also incorrect, even though they have some anxiety, but the lorazepam was not ordered, and it would not be our first line nursing intervention here. What we usually do is to implement non-pharmacological support, and possibly having them being referred to the psychiatry or psychiatry to address their other issues. Now let's move on to our next category. We have the psychosocial and preventive care. One of the answers here is to refer to psychiatry for anxiety. So this patient right now is overwhelmed emotionally. She's tearful, she's scared, she's refusing medication, and psychiatry can assess the patient's depression, maybe trauma, or maybe they have some anxiety disorders that may affect their treatment adherence. So this is a very important step. Another option that you should select is to educate on safe sex practices, because this patient has a history of unprotected transactional sex. And we know that sexual health education is very critical to prevent further transmission, and this will promote informed safe behaviors as well. Another option that you should select is to arrange case management for shelter support, because our patient lives in a homeless shelter and there's housing instability, which is the major barrier to continuity of care. And the case manager in this action will be able to help link the patients to resources like housing programs or maybe food banks or maybe Medicaid. So this is a huge step as well. Now, another option that you should select is to provide counseling on human immunodeficiency virus stigma. The reason for that is because the patient delayed seeking care due to fear of discrimination. And we need to address the stigma, which will help improve trust, to promote openness, and also to encourage long-term engagement with care. Another option that you should select is educate on medication adherence, because antiretroviral therapy effectiveness depends on daily consistent use, and patient education early in the treatment will build patient motivation and understanding about the consequences of missed doses, including drug resistance. So this is very important. Now, the incorrect option here is to refer to peer support group for human immunodeficiency virus patient, even though this one is valuable for long-term support, but this is not really gonna answer for the immediate need for this patient. And with early hospitalization, our focus is on stabilization, not about group therapy. And this is something that can be offered once the patient is emotionally and physically stable. Now, lastly, we have monitoring category. And one of the correct answers that you should select is monitor for signs of immune reconstitution inflammatory syndrome, given that the patient worsened clinically after starting the antiretroviral therapy. And monitoring for iris here is very critical. Another is to assess oxygen saturation and respiratory rate, because these are direct indicators of the patient's pulmonary status, which has shown signs of hypoxemia. Her saturation was 90% and the respiratory rate was 26 cycles per minute. So frequent monitoring will help guide us in the escalation of care as well. Next, we have to select monitor daily weight for nutritional status, because our patient's BMI and weight loss is very concerning. So this is going to help monitor malnutrition severity in response to our interventions. Another thing that you should highlight or select is monitor liver function test for antiretroviral therapy toxicity, because we are administering the antifungals, fluconazole, which can also stress the liver. And it's very important that we are keeping an eye into the AST, ALT, possibly the bilirubin levels to help detect hepatotoxicity, and so that we can help in possibly adjusting dosage as ordered by the medical provider, of course. And lastly, we have observed for signs of bleeding due to thrombocytopenia. Remember this time that the platelet count in this patient is 110,000 microliter, and she has those petechiae, which signal bleeding risk. And so as the nurse for this patient, you need to watch for nosebleeds, bleeding in the patient's gums, and hematuria, and make sure that you report these to the healthcare provider so that we can monitor this patient all the more. And so the last option, check blood pressure for hemodynamic stability. This is important in general sense, but the patient that we have in the case scenario has stable blood pressure, and it is not the most relevant or urgent parameter in this context of worsening oxygenation and the nutritional decline and the potential IRIS or the IRS. So I hope that you're able to get all the correct answers here. Moving on to our next test item, we have a drag and drop rationale item. So it says here, the nurse is addressing the patient's refusal of blood draws on day 3 due to fear of antiretroviral therapy toxicity. So what you need to do here is to drag and drop the interventions below into the correct order of priority, 1 being the highest, 8 the lowest. Then select the rationale for the highest priority intervention. Now, we have the following intervention options. One is to refer to case management for social support, administer ondansetron for nausea, monitor for immune reconstitution, inflammatory syndrome signs, use therapeutic communication to explore fears, consult psychiatry for anxiety management, educate on antiretroviral therapy side effects, administer antiretroviral therapy. We got those two, or we got that combination drug, dolutegravir, lamivudine, and tenofovir, and initiate Mycobacterium avium complex treatment, which is the azithromycin and ethambutol. We also have the options for the rationale. One is mitigate social determinants impacting. We have clarifies misconceptions about medication safety, detects complications of immune recovery, addresses underlying psychological barriers, reduces nausea to improve antiretroviral therapy tolerance, builds trust to facilitate treatment adherence, prevents rapid human immunodeficiency virus progression, and lastly, treats life-threatening opportunistic infection. So in this case, you have that patient on day 3 of their hospitalization, and now she suddenly refuses blood draw, right? So she said that these medications are poisoning her. That's a huge red flag, not just medically, but also emotionally. This patient is scared, she is losing trust, and if we don't handle this right away, she's going to start shutting down completely. Now, how are we going to approach this patient in this scenario? We're going to take a step back and really look at why she's refusing. It's not about being difficult. This is all about fear. There's anxiety component, maybe even post-trauma. And if we push harder on having her take those medications or to push those procedures before addressing that fear, we're going to lose her trust. And so let's go to the prioritization here. So what do you think would be the highest ranking intervention that you should have in this test item? The correct answer here should be 2, use therapeutic communication to explore fears. Now, the question is why it goes first. The reason for that's because you cannot fix a problem up until if you don't really understand what's going on. Now, this patient believes her medications are hurting her. It's not helping her. And so that's not something we can ignore in this case. Now, your job is to listen to the patient. You have to use calm, non-judgmental language like, can you tell me more about what makes you feel that way? And so this is really going to help start build that trust. And if there's no trust, nothing else is going to work. Not education, not medications, not even lab draws. And so this step is all about opening the door. The next priority here should be to consult psychiatry for anxiety management. Now, why now? It's because once she starts opening up, you might notice this fear runs really deep. Maybe there's paranoia, could be trauma, or maybe mental health condition underneath. And that's where psychiatric consult comes in. So it's going to let them do a deeper assessment basically, and it's going to help the patient with their anxiety, also determine their coping strategies, or even maybe they can help with incorporating medications as needed. And in this case, you're not handing her off to another person. You're actually bringing another backup. So this is a good choice to put it on the second rank. Now, the third rank here should be educate on antiretroviral therapy side effects. Now that she's listening, she's a little calmer and more open this time, you can now gently correct the misconception. And this time you can explain that side effects are normal and expected, they can be manageable, and that medications are not that toxic but life-saving. And around this time, what you need to do is to use plain language. Do not overwhelm her with so many information. So this is going to help her feel like she's back in control. Now let's look into the fourth rank here. It should be to administer the antiretroviral therapy. So this is a time when you're basically going to introduce or to administer the drug itself. Now that she's feeling that she's supported, she has the correct information, and assuming that she agrees, you can actually now give the medications needed. And if you had rushed in administering the medication, this could have backfired early on. But if you're going to put this on the fourth rank, she's more likely to take the medication willingly, and that means we're actually making a real progress. For the fifth rank, it should be to initiate Mycobacterium avium complex treatment with azithromycin and ethambutol. So we're going to treat the infection here, which is very critical. But then again, it only works if she is on board in taking the drug. Now, once her HIV medications are underway, we need to follow up with treatment for this opportunistic infection. And by now, we have earned her trust enough to start adding other essential medications. The sixth rank should be refer to case management for social support. This is part of the long game. She's also dealing with housing issues because she lives in, she's homeless. She lacks insurance. And the case manager can help with that, but it's not going to solve today's crisis. So that's why it is appropriate to put it on the sixth rank. We know that this step is important for continuity of care, but it's not just as urgent compared to the other actions. We have our seventh rank. This is going to be administer ondansetron for nausea. This is part of our supportive care. And the nausea isn't the reason that she's refusing the treatment. And once we've got her taking meds, then we can treat side effects like nausea to help her stick with a plan. And lastly, we are going to select monitor for immune reconstitution and inflammatory syndrome signs. This is good to know, but not yet. And monitoring for iris is important after we have started the antiretroviral therapy, but you cannot monitor anything if the patient's still refusing laboratory. And so this steps happens at the bottom, right? When she's back on track and we have already rebuilt that trust. Now for the rationale here, the correct answer should be build stress to facilitate treatment adherence, because none of the other steps matter if she doesn't feel safe. And you could have the perfect medications in this case, maybe the best specialist and the strongest care plan. But if the patient doesn't trust you, or if she doesn't believe that she's safe, no, she's not going to follow through. And that's why you got to do this step by step. All right, let's move forward to our next test item. We have here a matrix multiple choice item. So let's take a look quickly into our vital signs. Looks like it's the same information here regarding the temperature, pulse rate, respirations, blood pressure, and saturation. And let's take a look into the nurse's progress notes. So let's jump right into day 3 at 6 o'clock. It said about worsening dyspnea, productive cough and fever, oxygen saturation 90% on room air, sputum culture positive for Mycobacterium avium complex. Patient tearful, refuses blood draw, stating these drugs are poisoning me. Psychiatry consulted for anxiety, blood draw completed after reassurance, labs pending. Let's jump into the lab values on day 3, and I think these were already mentioned earlier, so I want you to scan carefully on these information. And we have the diagnostic studies as well. from the HIV-1 antibody test through serology for the syphilis. I think we already tackled these as well. Now, your task in this test item is to complete the matrix below by selecting the appropriate clinical judgment for each finding. Now, how are you going to approach this test item? So with this matrix style question, I want you to think like a detective and think about the manifestations that they had. Is the fever rising, or is there some improvement with their temperature? Are the lab values trending in the wrong direction, or are the symptoms now worsening, or are there new symptoms that you should pay attention to? And you also need to check if the findings that you will be seeing will require you to intervene right away. So here's our matrix. So the options for you, we have improving, stable, worsening, and critical. Now let's look into the finding. On the first finding, it says temperature 102.6 degrees Fahrenheit. What do you think about this? And I want you to go back into the assessment findings, the lab values, and also the vital signs. So the correct answer here is worsening. Now, the reason for that is because during admission, the patient had a fever of 101.4 degrees Fahrenheit, and now it's up to 102.6 degrees Fahrenheit. So this is now a spike. And I want you to keep this in mind, that whenever there is an increasing temperature after starting the antiretroviral therapy, that could signal immune reconstitution inflammatory syndrome, or the IRIS. Again, this is a condition where the recovering immune system is overreacting to an existing infection. Or it might mean that the Mycobacterium avium complex infection is getting worse despite the treatment. So the higher temperature tells us that her body's inflammatory response is actually ramping up. This is not a good sign. This is not considered critical, but definitely worsening. Now, moving into the next finding, nausea resolved with ondansetron. This is improving, because she had nausea after her first dose of the antiretroviral therapy, which is expected. This is common in patients taking that medication or dose medication. But now with the administration of ondansetron, her symptoms are gone. And this shows she's tolerating the treatment better, which is a big win. And nausea is one of the main reasons people stop taking the antiretroviral therapy. And so when you're managing it with that medication, it successfully means she's more likely to stick with the treatment. So we're basically had successfully managed the side effect effectively here. Now, look into the next finding here. It said CD4 count 140 cells per cubic millimeter. The correct answer here is stable. So let's go back into the table for the lab value. On day 1, it said that the CD4 count is 150 cells cubic millimeter. On day 3, it's 140 cells per cubic millimeter. Why is it that we are calling this a stable instead of worsening, even though that there is a drop from 150 to 140? Why is this not alarming? Well, this is a small change, and a drop of 10 cells per cubic millimeter is very small. This is expected. And the CD4 counts can either go up or it can go down a little, especially right after they start the antiretroviral therapy. And if you're going to look into this, these two values, 140 and 150 are actually on the same risk level. These two are very low. They're not much different. And both are under that level of 200, which means that the patient's immune system is very weak. And the drop that we are seeing here is not enough to make the condition worse. And take note that CD4 counts don't improve right away once they start the antiretroviral therapy. It's going to take weeks, even months, for their CD4 count to increase. And so early changes are not reliable signs of progress or even decline. Let's go into the next finding, dyspnea with oxygen saturation, 90%. Now, if you compare it to the vital signs, go back into that table. This is critical because she was saturating at 94% on room air. Now this time she is at 90% with shortness of breath. There's increased respiratory rate, and this could indicate the iris or worsening MAC or the Mycobacterium avium complex infection, or maybe a new problem like the pneumocystis pneumonia. So you have to consider this as a critical finding. So she's basically slipping into a respiratory compromise, and definitely she requires immediate intervention. We're gonna have to increase oxygenation. We need to include respiratory support and maybe placing her in the intensive care unit as ordered. So this is not just a trend. This is basically a threat. This is a life-threatening change. She's basically in trouble, so we need to intervene really fast here. Now we have the next findings. She is, it said, patient refuses blood draw. So this is categorized as worsening because the patient was cooperative earlier. Now she is refusing the blood draws, and she stated that the medications are poisoning her. And so this one signals that there is a sudden shift in her mental or emotional state. So this reflects that she is experiencing fear. There's paranoia, or could be mistrust, which is blocking critical monitoring. And definitely this is a psychosocial decline that needs therapeutic communication and likely psychiatric consultation and intervention. So this patient is disengaging from the care. So this is very dangerous. Not critical, but definitely worsening. Let's look into the hemoglobin of 9.8 grams per deciliter. What do you think about this one? This is categorized as worsening because the previous hemoglobin level was 10.2 grams per deciliter, if you want to go back into the table. And she is becoming more anemic, even though it's not severe yet. This one could cause more fatigue, poor oxygenation, and this is also reflecting bone marrow suppression. Could be nutritional issue or maybe chronic disease. It's not really going to call for a code here, but it's a trend that we don't want to ignore. So we're going to categorize this as worsening, not critical. Now, what about platelet count of 110? This is also considered worsening because this level dropped from 120,000 if you go back into the lab data. And the declining trend really puts her at risk for bleeding, especially if you already saw the petechiae on the lower extremities. And so you need to think here about maybe holding the medications that increase bleeding risk or having hematology to consult this patient. So she's actually inching closer to a bleeding risk zone this time. Now we have our last finding, serum creatinine of 1.0 milligrams per deciliter. This is categorized as stable because this is just slightly increased from a 0.9 milligram per deciliter to 1.0. Very slight increase, and it's still within the normal limit. So it's okay for now. There's no sign of acute kidney injury or drug toxicity yet. We need to keep monitoring, but there's no red flags at the moment. So this simply tells us that the kidneys are working steadily, no urgency at the moment. So for this test item, You gotta compare each finding to the baseline because trends matter more than isolated values. And keep this in mind that context is key. So a laboratory value that is abnormal, but if it's stable, it's not as urgent as a normal lab trending downward. So I want you to keep that in mind. Also, don't forget the behavior, especially if there's emotional withdrawal or maybe a refusal of care or maybe anxiety. That is a clinical change as well. And I want you to think about labeling as critical only when there's an immediate threat to life, especially if it's compromising their airway, their breathing, or maybe it's pointing towards sepsis or maybe cardiac instability. So I want you to reflect on those criteria. Alrighty, let's move on to our last test item for this session.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
This is a trend test type, and it says the nurse analyzes the patient's clinical trend over 5 days since admission, and based on the data in the table below, select the most appropriate action to take next on day 5. So we have the following parameters. It said about CD4 count. On day 1, it was 150 cells per cubic millimeter. On day 5, it's 140. For the HIV viral load, 450,000 copies on day 1. For day 3, it's not repeated. For the temperature, 101.4 degrees Fahrenheit on day 1, an increase at 102.6 on day 3, and down to 101.8 degrees Fahrenheit on day 5. Now for the symptoms, there were fevers, night sweats, dyspnea on day 1. On day 3, there was worsening of dyspnea, there's productive cough, and day 5, persistent dyspnea. For the oxygen saturation on day 1, it was 94% on room air, 90% on room air for day 3, and 88% on room air for day 5. And for the heart rate, 96 for day 1, 104 for day 3, 108 for day 5. Blood pressure on day 1 was 110/70, 106/66 on day 3, and 100/62 on day 5. Chest X-ray was normal on day 1. However, on day 3, it showed bilateral ground glass opacities. It was not repeated on day 5. For the sputum culture, it was not obtained on day 1. However, on day 3, it showed positive for Mycobacterium avium complex, not repeated on day 5. And the medications initiated on day 1 were the dolutegravir, lamivudine, tenofovir, and the trimethoprim, sulfamethoxazole, and fluconazole. On day 3, the patient was receiving azithromycin and ethambutol, and no new medications given on day 5. So what do you think would be the significant changes here along the parameters between the 3-day period? So the question here, it's basically for you to select the most appropriate action to take next on day 5. So we have the options: continue the current treatment and monitor, initiate high-dose prednisone for immune reconstitution inflammatory syndrome, request bronchoalveolar lavage to rule out pneumocystis jirovecii pneumonia, administer supplemental oxygen and consult pulmonology, and switch antiretroviral therapy due to virologic failure. The answer for this one is administer supplemental oxygen and consult pulmonology. Why do you think this is the answer here? Well, going back into the scenario, the patient is hypoxic. Her saturation has fallen from 94% room air to 88%, which is below normal. Now, pay attention to her respirations. She is now breathing a lot faster at 26 cycles per minute, and her heart rate is also elevated, 108 beats per minute. And now she's also showing signs of respiratory distress. And the imaging from the earlier showed ground glass opacities, which are classic for the PJP and can also be seen in the iris. Now, as a nurse in this case, you should treat the patient by administering oxygen here because of a life-threatening hypoxemia. This is going to prevent respiratory failure. And if you're also consulting pulmonology, they're gonna perform possibly further testing, maybe bronchoscopy, or they can order bronchoalveolar lavage to confirm the cause, whether it's iris or PJP or maybe both. And so this is really going to guide them to have a much more targeted treatment. And this option can also directly address the most urgent issues here. We got an issue about breathing, and the perfusion is so compromised this time. Now, if you selected continue the current treatment and monitor, this might seem okay if the patient were stable, but hey, clearly the patient is getting worse. Pay attention to the hypoxemia, her respiration's going up, tachycardia. These are signs of compensation. So if you're just monitoring without acting on the problem, this is going to lead to the patient's respiratory failure. If you selected initiate high-dose prednisone for immune reconstitution inflammatory syndrome, yeah, prednisone is sometimes used to treat severe iris, but only after ruling out the infection like the PJP. So if you're giving the steroids too early, this can weaken the patient's immune system. So this is going to make the infection worse, right? And if you selected request bronchoalveolar lavage to rule out pneumocystis jirovecii pneumonia, you could be on the right track with the diagnostic, but here's the catch. Nurses cannot order or really request this type of invasive procedure. This is a healthcare provider's responsibility. And our role here is to recognize the problem and notify the provider, and not to it's not to directly order the test. So the nurse should consult pulmonology, and our scope is to coordinate care, not to decide which diagnostic procedures that should be done for this patient. And if you selected switch antiretroviral therapy due to virologic failure, this sounds kind of proactive at the moment, but there is no proof yet that the antiretroviral therapy is failing. And we have not repeated the HIV viral load test as of now. So there are no labs to confirm that the virus is not responding. And at the moment, the patient's symptoms are more likely due to an infection or immune reaction, not the antiretroviral therapy itself. And so changing the HIV medication without confirmation could disrupt the treatment, and it can delay proper care for this patient. And the bottom line here is to make sure that when you have the trending data, this simply means that the patient is worsening, and you got to prioritize life-threatening signs, especially that she is manifesting hypoxemia. It definitely needs immediate action. And keep in mind, you have to support breathing first, then work with the team to figure out the costs. So this is the end of our discussion today. If there's one thing to take with you, it's that good nursing judgment comes from more than just knowing the content. So it's about pulling it all together at the bedside. So I want you to keep practicing how to recognize what matters most, respond with purpose, and also reflect on your outcomes. So these are the skills the NCLEX is looking for, and more importantly, the skills your patients will depend on in the future. So keep at it. You're building more than test readiness. And don't forget to subscribe the YouTube channel for more NCLEX prep content, and give this video a thumbs up and share it with your study buddies. I'll see you in the next review session. Thanks for watching.